It's a pleasure for me to be able to give a presentation this morning from the lovely island of St. Lucia, where I am vacationing. I'd like to talk a little bit about clearing out the house and approach to some clear cell salivary gland tumors. I do wish I could say I did not have any disclosures, but of course we do make 5 cents in royalties from a variety of different companies. As you know, if you think about the general considerations for salivary gland tumors, they only comprise about 1% of all neoplasia, and therefore it's a very uncommon tumor type to come across in your daily practice, and still it has a wide diversity which causes considerable problems. As you know, they are most common in adults, and of course almost all head and neck lesions do have some sort of fine needle aspiration as the first screening modality. The increase of core needle biopsy has also been seen over the last several years. There's not really very much known about the etiology, and of course the clinical stage is quite important, but one of the things that I think has caught up is the molecular techniques. So if you look at the molecular findings of tumors and give this presentation 5 or 6 years ago, there would only be about 4 or 5 tumors that you would have been able to discuss where the various molecular findings had been identified. However, now you can see that we have really filled in very nicely many of the salivary gland neoplasms with both the primary molecular alterations identified, and then over time, many different alternative partners or new fusions or new point mutations have been identified in many of these particular lesions. As you can see with some of them, like intraductal carcinoma or salivary duct carcinoma, there are truly a wide diversity of the various findings that can be seen in these tumors. One of the things I always like to discuss kind of as a preamble to what we're doing in salivary gland tumors is discussing the salivary gland distribution or tumor type distribution, because I do think that that is really quite significant. So if you think first about just salivary gland tumors in general, you can see that the vast majority are accounted for by the parotid gland and submandibular gland as the major salivary gland component. And in fact, 86% of all of these tumors are accounted for in the major salivary glands. So therefore, if you're thinking about salivary gland tumors, at least recognizing a major salivary gland location is probably significant. However, when you look at the minor salivary glands, you can see that there is still some dominant findings here as well, with the palate accounting for the vast majority of these tumors, while a much smaller number is accounted for in other anatomic sites, such as the lip and tongue, cheek, and then a variety of other things, such as the larynx or nasal cavity, nasopharynx, oropharynx, etc. Now, one of the other things that I think is significant is trying to think about the actual tumor histology in these locations, and there is quite a helpful finding with that as well. So when you think about the major salivary gland distribution site, you can see that pleomorphic adenoma accounts for more than half of the overall neoplasms in that location. And then when you add in all of the other benign tumors, you can see that more than 3/4 of the neoplasms in major salivary glands are benign lesions. So ladies and gentlemen, when you think about this and you think about pleomorphic adenoma and basal cell adenoma, monomorphic adenomas, the Wharton tumor, some of these other tumor categories, it really is 7 or 8 out of 10 times that it is going to be a benign tumor. So really, this is something that I do think about very carefully before rendering a malignant diagnosis, no matter what is going on. I mean, it really does need to be something that you at least consider. Then if you go to minor salivary glands, you actually have quite a remarkable separation from that. And in this particular instance, you will notice that pleomorphic adenoma still is by far and away the most common neoplasm in this location. So when I think about salivary gland tumors in minor salivary glands, still it is a pleomorphic adenoma as the single category that is the most common. But now if you look at the overall neoplastic consideration, you can see that more than 50% of the tumors are malignant. So this is in contrast to major salivary glands, and again, something that needs to be considered. And so when I think about the general rules for these particular tumor categories, the smaller the involved salivary gland, the higher the possibility of the tumor being malignant. And so that is a general rule of thumb that serves me quite well as I at least initially approach some of these very limited or core needle biopsy type specimens. A few things to consider as well in trying to separate between benign and malignant is kind of the rate of growth, the relationship to the surrounding tissues, circumscription, and cytologic atypia. And as I've listed each of these things, there really can be quite a remarkable overlap between benign and malignant. So for rate of growth, if you think about a salivary duct carcinoma, especially when it's arising as the carcinoma type in a carcinoma expiomorphic adenoma, this is a tumor that may have been present for the last 10, 15, 20 years, and then suddenly there is a remarkable change in size of the lesion or growth of the tumor. The relationship to the surrounding structures, of course, is quite significant as well. And in general, the benign tumors tend to be more circumscribed. Cytologic atypia, of course, as you know, with something called pleomorphic, obviously this tells you there's a wide variety of both patterns and histologic types that make up that particular tumor. So, here is a core needle biopsy just to kind of accentuate this point. And I think if you look at this carefully for a few moments, you would be able to see that here is the neoplastic tissue, and probably would not be too hard pressed to say this looks like it is probably an adenoid cystic carcinoma. However, if you now look at the radiology, you can tell that this really is just a huge destructive lesion expanding from the maxillary sinus and going into the adjacent nasal cavity, the orbit expanding into the soft tissues going into the oral cavity. So it really is a remarkably destructive tumor. And so many times when I approach these lesions, for me, the gross is actually the imaging. And so when I look at a core needle biopsy of a salivary gland tumor and then review the imaging findings, even if it's just the imaging report, here I am showing you the image because I think it's much more dramatic than reading through a very long, detailed description of what they're seeing radiographically. But if you see that, and you see that each of them talks about bone destruction or compartment destruction or expansion into adjacent structures, this really is something that can be used to help you in your overall diagnostic interpretation. So let's talk a little bit about classification for a moment. This was the 2003 classification held in Lyon. You can see that there we all were nicely outside and enjoying ourselves. Unfortunately, the meeting for the 2017 edition was in January of 2016, and here we all were lined up inside. And then, alas, the meeting last year was all held virtually, as has everything been for the last several months. And so here we all were on a Zoom meeting, still animated discussions around what the criteria should be and how the classification would be determined. So if you think about where we have gone, you will notice that from the 2005 edition, there were 42 diagnoses. 2017 had 45 diagnoses, and now we've come down to 36 diagnoses in salivary gland. So this is not to say that there are fewer lesions, it's just to say that there has been a amalgamation and harmonization of the terminology and how we approach these tumors. So with that, I'd like to actually try and show a little bit about the making of the sausage, if you will. And so what I'd like to do, and I hope that this link works because I'm going to try and drive their live site, and let's hope that it is going to work. So this is the head and neck tumors from the World Health Organization. As you can see, there are a variety of different roles. And then, of course, as you look through this, the nasal cavity, nasopharynx, salivary gland lesions are all included. I'm just going to talk about salivary gland at this particular point because, of course, that is what we're discussing at this moment. And let's talk about something like epithelial-myoepithelial carcinoma. So the lesion is given a word limit. You can see that we've reached it. There are a number of responsible editors and authors, and then imaging. And then it's divided out into the definition, what any terminology subtypes may be, what the localization is, clinical and imaging features, epidemiology, pathogenesis, macroscopic and microscopic, the immunocytology, and of course, prognosis, and then a variety of different references are incorporated. One of the really nifty things, though, is about the images. You can see here, there are several different images that are incorporated in this lesion, and of course, you would be able to look at them on higher magnification. But the real major coup for this book is the fact that we have been able to upload whole slide glass images or virtual slides of the glass image. So here I'll drive one just as an example, and I'll expand it so you can see it full screen. But you can see here you are now, as the user of this book, able to drive a virtual slide that has been vetted by the group in order to be able to say, if I want to look at a true live case of epithelial-myoepithelial carcinoma, here is an example that someone else has looked at and agreed has the histologic features of that central luminal ductal component surrounded by the myoepithelial cells. So that is one of the really fantastic findings in this book. One of the others that I think, especially when one looks at the online version, is you can see that there are a whole host of different references that are included by PubMed ID. So then when you log into the book, and here I've just brought up epithelial-myoepithelial carcinoma as a diagnosis, you click on the link and it automatically launches into the PubMed, and now you're able to look at the source material from which that particular finding was documented. And so I think this is a great way to share information with the clinicians in order to be able to come up with shared information. So as you can tell, the salivary gland chapter as a whole now only includes one entity for this. So in other words, there's only one chapter on salivary gland lesions. So even though we know they occur in the oral cavity, they occur in the ear and temporal bone, they occur in the larynx, they occur in other anatomic sites, they have instead all been aggregated into one location, and therefore you can just look them up in that site rather than having them recur or repeated in other areas of the book. So this is part of the reason why there are fewer entities discussed in each of the anatomic site divisions. Then one of the other major considerations for this book is specifically with mesenchymal and stromal tumors, even the bone lesions, hematolymphoid lesions, germ cell tumors, and even melanoma have all been aggregated into their own chapters. So in other words, a lipoma of salivary gland is not discussed unless it is a sialolipoma, and then it is. But if you think about smooth muscle tumors like a leiomyoma, that is not going to be presented in each of the anatomic sites uniquely. It is just aggregated into that mesenchymal chapter where each of the anatomic site descriptions are described under part of the site. So it's a really nice way of separating out some of these other lesions from what were otherwise considered duplications within the book. Finally, the genetic tumor syndrome section is included as a unique entity as well, and there are several different tumors presented in that, specifically as they relate to primary head and neck presentations of those particular syndromes. So clearly, a whole bunch of different syndromes can have a head and neck related findings, but the tumor syndrome associated finding where it has a primary presentation in the head and neck is what is focused on in those particular chapters. So if you think about the 2021 book, which obviously is going to come out this year in 22, you can see the diagnoses under the benign. We do have sialolipoma as a unique mesenchymal entity just found in salivary gland sites only, and then of course the malignant tumor category. So when one looks at the malignant tumor category, what I would like to focus on in the next few minutes of this discussion is really those tumors that fit into the clear cell differential, and I'm highlighting several of them here, and obviously will now present them in a little bit more detail. There has been a correlation between the ICCR, or International Cancer Collaboration Reporting System, and the IARC, which is the publication arm of the World Health Organization, so that these two are now harmonized, where there are data sets that are recorded. And of course, the nice thing about this is they are free to use by just going to the ICCR website. So it's a very nice way to have standardization globally for these particular tumor entities. So let's try the case. 63-year-old man presented with a tongue lesion that grew slowly over the last several months. Here is an example of this lesion, and you can tell that it really is quite large and expanding out into the base of the tongue area. So let's drive a slide. It's always nice to drive one of these slides. And so here it is. You can see that on low power, let me just go a little bit higher so you can see here that this is obviously tonsil epithelium and a lymphoepithelium present here. So you can tell that the base of tongue actually is being involved by this neoplasm. On low power, I think that the remarkable infiltrative appearance of the tumor is quite easy to identify. When you go up to higher power, there is a very remarkable and well-developed sclerotic or acellular eosinophilic fibrosis. It is quite hyalinized, no matter where it is that you look in this particular example. And then as you look at the neoplastic proliferation, I think that you can tell that there are a variety of different components. And in fact, when you go up to high power, and let me just go over here as a high power example, you can tell that there is quite a clearing out of the cytoplasm in many of these cells with a very prominent cell border. Mild pleomorphism is easily identified, although it's not very profound, right? All of the neoplastic cells look quite similar one to another. And then as you move around, you can tell that these sheets and nests are formed obviously separated out by these bands of acellular fibrosis. But as you look around, you can see that the clear cell pattern is quite easily identified in the majority of the cases, although, maybe in an area like this, if I were to go up to high power and say, do you think that there may be some areas of intercellular border formation? Could there be spinous processes between this? Could this be a squamous differentiation? In other areas, is this, are these little areas perhaps mucinous differentiation or mucin globules, cytoplasmic globules? And so with that in mind, you can see that the differential for these particular lesions are going to encompass quite a number of tumors. And so what I'd like to do in the next half an hour or so is go over the differential for clear cell tumors with hyalinizing clear cell carcinoma, adenosquamous carcinoma, and acinic cell carcinoma, mucoepidermoid carcinoma, myoepithelial carcinoma, epithelial-myoepithelial carcinoma, renal cell, and then, of course, squamous cell carcinoma with the other S in that is sclerosing microcystic adenocarcinoma. So you can tell that I'm going to have a mnemonic going on for you at some point in this presentation to help you memorize these findings. So let's just put it graphically for a few moments and let you look at this. And one of the things that I think you will see as you read through each of these particular groups is there is actually quite a remarkable similarity with the immunohistochemistry. So there really is significant immunohistochemical overlap with many of these cells showing, with many of these tumors showing quite a remarkable immunophenotypic overlap. So one of the other things that I think is interesting is as I highlight hyalinizing clear cell carcinoma, squamous cell carcinoma, mucoepidermoid carcinoma, and metastatic renal cell carcinoma, you really can tell that in this case, it is an example of a single cell population, right? So these are really tumors that are single cell in their origin. Whereas with adenosquamous, acinic cell carcinoma, a mucoepidermoid carcinoma, epithelial-myoepithelial carcinoma, and sclerosing microcystic adenocarcinoma. These are tumors that have a biphasical dual cell population. So in other words, the immunophenotype in these tumors is going to show two different cellular components in order to be able to come up with the diagnosis. So I think when one approaches the immunohistochemistry on these lesions and recognizing the way in which the immunophenotype is distributed would definitely help you narrow down the focus of what it is that you're going to come to as a diagnostic category. So let's start out with the obvious diagnosis in this case, which is the hyalinizing clear cell carcinoma. And as you all know, this is a low-grade salivary gland type carcinoma, having both clear and eosinophilic cells, usually some sort of hyalinized stroma in the background, and a very strong association with the EWSR1 rearrangement. So the most important thing, first of all, is really to think of this as a diagnosis of exclusion as well, because it needs to lack features of other clear cell salivary gland tumors. And so this is one of the things that really needs to be done in order to make sure that there are not other features present. So one of the interesting things about this is there is some significant argument around the fact that could this actually be an example of a tumor that is in fact a squamous cell carcinoma variant. And of course, that is what is being considered by many authors at this particular time. You'll notice that the minor salivary gland is by far and away the most common location for this, with more than 80% of the tumors presenting in that anatomic site. Usually they are unencapsulated, but definitely infiltrative. They often may attach to the overlying surface epithelium and sometimes will even have a pagetoid spread. And then they are arranged in either sheets and cords and nests or trabecular architecture of these monotonous epithelial cells with some variable degree of both eosinophilic or cleared cytoplasm. So with that in mind, you can have dilatation, which will result in cyst formation. You may even have some ducts. Occasionally, mucocytes are seen in the tumor, as well as areas of squamous differentiation. So, of course, with that in mind, you can tell immediately that a mucoepidermoid carcinoma is certainly going to be a consideration as one of the differentials in this case. They're usually very prominent cell borders. Lots of perineural invasion is easy to identify. And then, of course, this desmoplastic fibrocellular stroma as a background hyalinized material is very characteristic for the tumor. Necrosis, increased mitosis, and pleomorphism is usually not present, and when it is, often signals that there has been a high-grade transformation of the tumor, although this is a very uncommon event in hyalinizing clear cell carcinoma. So I already showed this as I drove the slide a few moments ago, but just again to reiterate a very infiltrative nature to the tumor with a sclerous type appearance to it. prominent perineural invasion. I think here you can see that there is a very well-developed nerve over here with multiple nerve twigs present, and each of the nerve twigs is surrounded by this very prominent clear cell neoplastic infiltrate. The neoplastic infiltrate may not appear as clear in this particular case, and so when you think about it here, you can tell that there are these very well-developed areas of hyalinization or sclerous appearance, expanding into and actually compressing some of the skeletal muscle. But again, sometimes the neoplasm and the neoplastic cells with histiocytes may be a little difficult to be able to separate. So here is an example of more of a sheet-like appearance to the clear cell compartment, where you can have a bit more of a prominent and solid architecture, while in other areas it has a very, very well-developed acellular hyalinized stroma that is the characteristic for this neoplasm. They may form these very nice bands, and the bands will then separate out into individual single cell or cord-like appearance to the neoplastic proliferation that can be seen in this case here. So when I think about this tumor, there's usually some sort of arc of development or arc of changes that you can see in the tumor, with an area like this appearing much more squamous, where there's a opacification of the cytoplasm, prominent intercellular borders, and perhaps even some intercellular bridges. But you can still see that there are a few clear cells present in this case. A much more prominent clear cell component, but still with the sort of squamoid appearance in the background, while an area like this is almost exclusively of the clear cells. And finally, a space like this is much more difficult to tell what you're actually dealing with, because there's no hyalinization in this space. And this is probably the area where immunohistochemistry would be the most value to be able to make the separation between these tumors. Mucin production can be seen here. You can see it within the lumen, but I can assure you that it is prominent within some of these spaces as well, as can be highlighted by a number of stains, such as either a PAS diastase or mucicarmin stain. Then you will notice that there is positivity with a number of different keratins, but of course the keratins are all a single cell population. So in other words, all of them stain similarly, and the same with P63, P40, and CK56, all highlighting this. And as you know, those are markers that can be seen in squamous differentiation or in tumors like a mucoepidermoid carcinoma, which is why that differential can be quite challenging. Then you will notice the negative markers for any of the myoepithelial-derived markers. And as I've already suggested, there is a well-known EWSR1, and in this case, ATF1 fusion. So if you do an EWSR1 FISH, it can tell you that EWSR1 is involved, but of course it doesn't tell you what the fusion partner may be in that particular case. So let's look at some of the Here's an example of mucin. So here, first of all, you'll see that it is luminal mucin, which really does not count. But over here, you can see that it is intracytoplasmic mucin, as you can see in this example here and here. And therefore, there is genuine mucin production, although isolated in many of these tumors. Very strong and prominent single cell population with P63, obviously the same with P40, because these are equivalent in this particular setting, although I think the P40 is much more sensitive as a marker in this tumor. When you look at the myoepithelial markers, and of course here I've selected an S100 protein just because it so nicely highlights the nerve, and yet you can see that the neoplastic cells are completely negative around it. And then a few other markers such as smooth muscle actin you can see is also negative in the neoplastic cells. The EWSR1 FISH, of course, here very nicely showing a break apart, but again, not telling you much information about the fusion partner. So let's move on at this particular point then to the next tumor. And I'm going to talk about the sclerosing microcystic adenocarcinoma because it is a biphasic neoplasm, but it's so incredibly rare. It's very, very uncommon, although it does affect the minor salivary glands. It is a biphasic tumor where there are cords and nests in a very, very dense collagenized stroma. And so here the biphasic appearance is what is helpful because you'll get luminal CK7 reactivity, while the myoepithelial cells will mark with a variety of myoepithelial markers. So far, there's been no recurrence or metastasis, so there is kind of a question as to whether sclerosing microcystic adenocarcinoma is actually a carcinoma category or not. But of course, when you have really well-developed perineural invasion, one should at least consider that. So here you will notice very, very heavy sclerosis or hyalinization in the background, infiltrating out into the adjacent skeletal muscle. So again, the infiltrative growth is part of why it's considered in the adenocarcinoma category, albeit indolent. And then when you look at it on high power, you can tell that they are very well developed basal and myoepithelial cells at the periphery with a central area of epithelial differentiation. I'm not going to talk about the immuno in that case because it is just so obvious, but let's now talk about squamous cell carcinoma, because when you think about a salivary gland tumor category, of course, when you're in the oral cavity or minor salivary gland locations, squamous cell carcinoma is much more likely to be the tumor category that you're going to come across. So when you think about anything in the upper aerodigestive tract, squamous cell carcinoma is always in the background, right? It is making up, 85 to 90% of all of the neoplasms in the upper aerodigestive tract. When you consider, larynx, oral cavity, sinonasal tract, etc. So while this lecture is focused on the salivary gland category of clear cell components, you do need to think about the clear cell squamous cell carcinoma. So remember, it will have a surface origin. Keratinization is generally seen to some degree. And then, of course, you have a wide variation in the amount of squamous differentiation. Tumor necrosis and mitoses are usually easy to identify. And of course, there is going to be a desmoplastic stromal reaction. This is one of the features that we utilize to be able to make a separation between these neoplasms. So again, it's a single cell population though, right? So it's just going to be positive with all of these markers in a single cell category. And of course, you already know that there are so many factors that go into the prognosis for this tumor. So if I just start off on an intermediate power here with a clear cell component of a squamous cell carcinoma, I think everyone here can see how there is a remarkable overlap with what I was just showing you with the hyalinizing clear cell carcinoma category or any of the other lesions that I'm going to discuss here in a few moments. But then as you move around with the tumor, you will begin to see that there is much more obvious keratinization and dyskeratosis, much more prominent intercellular borders, but still the clear cell component can be seen. And then finally, in another area, you can see that there's just very well developed keratinization in this area of the tumor. So again, when you look at these areas, you can see that there is a clear cell component to it, but usually the tumor is not just clear cell. You're always able to see some areas of squamous differentiation in the form of keratinization somewhere within the tumor. But side by side, if you look at both of these two tumors, I think you would be hard pressed to separate without any additional findings between a squamous cell carcinoma and a hyalinizing clear cell carcinoma category. So let's go on now to one of the kind of next category after squamous cell carcinoma is adenosquamous. This also is not particularly a salivary gland tumor category, but because it can develop in the upper aerodigestive tract as a biphasic tumor that shows both squamous cell carcinoma and glandular or adenocarcinoma in aggregation. Now, when one thinks about the oropharynx as an anatomic site, they are very frequently associated with HPV in that particular location. So there is a blending of the squamous and glandular components in many cases. However, often they are just two separate tumor categories where you can see well-developed squamous differentiation and well-developed glandular differentiation just juxtaposed next to each other, or in essence, maybe even considered collision in some instances where they seem to be two separate components. Very frequently, surface origin will be identified, and of course, mucin production can be seen in these tumors as well. They are much more biologically aggressive than squamous cell carcinoma and usually have a much more advanced stage, although at this particular point still, as it relates to the HPV, there is still a better overall outcome for patients who have oropharyngeal primaries. So it's a dual cell population, right? You're going to have those markers that are going to be highlighting the area of squamous differentiation, P63, P40, and CK56, while the adenocarcinoma can be highlighted by a CEA and or mucin production in those particular cells. So when I look at this area, I think you can tell that it is a sheet-like distribution showing what appears for all intents and purposes to be squamous differentiation. But again, you can see that there are focal areas suggesting glandular differentiation or at least lumen formation of a neoplasm. However, in this case, I think it's a little bit more obvious that you have genuine and well-developed glandular formation, and you will notice here it is a higher grade tumor. So as I've already suggested, the adenosquamous does tend to be a high-grade tumor, and so it'll have lots of mitotic activity in areas of pleomorphism and even tumor necrosis. One of the important things to consider, and especially when one is dealing with tumors of the oropharynx, although it can occur anywhere within an adenosquamous category, cilia can be seen, and cilia can still be identified within the malignancy. And so this is one of the exceptions when you think about, cilia in other anatomic sites. We often say, oh, I see cilia, it must be benign, but that is definitely not the case when you're talking about an adenosquamous carcinoma of the upper aerodigestive tract. So I think the glandular features of this tumor are quite well developed here, while the squamous feature is well developed immediately below. Here, it's a much more well-defined separation, where you can see that this is the area of squamous differentiation, although still the potential for gland formation can be seen, while this lower portion is much more obviously a glandular or adenocarcinoma component. Blending can be seen in hyalinization. So here you can see hyalinization, and then mucocyte presentation is seen here as well. And so you may say, well, how are you going to separate this from a high-grade mucoepidermoid carcinoma? And I can tell you that it is often impossible, because there's going to be a complete overlap of the immunophenotype. And so in these settings, performing a molecular study for the MAML2 as a confirmation of mucoepidermoid carcinoma will be quite helpful in that setting. So here you can see an example of intracytoplasmic mucin production, although clearly still there is mucin present in the lumen of the ductal or glandular differentiated areas as well, but the squamous cell component is completely negative with the mucin material. Let's go now to mucoepidermoid carcinoma, and specifically to the clear cell type, because that's where the differential would be the most specific. And if you think about it, mucoepidermoid carcinoma must have three components: mucocytes, intermediate cells, and epidermoid cells. And I'll say that that intermediate cell category is the one that is the most difficult, but they really are cells that look kind of between mucocytes and well-developed squamous or epidermoid cells, and yet they are still kind of a blend between the two. They are usually associated with MAML2 rearrangements, and I think that that is one of the most important things to at least recognize, but also know that other fusions can be seen, and especially when they are in the clear cell category. So EWSR1 with POU5F1 has been reported as well, and so mucoepidermoid carcinoma is not just identified by MAML2, with other fusions also seen. So when you think about the histology, they're often solid and cystic. Goblet cells can be seen with an intermediate and squamous cells. And then clear cells can sometimes be the predominant finding in these tumors, with a very sclerotic background quite frequently identified. So as you will see, biphasic immunophenotype in this tumor, with P63, P40, and CK56 highlighting the transitional and epidermoid component, with some of the markers more specifically or stronger, much more stronger reactivity in the intermediate cell than the epidermoid cell. And then, of course, CEA and mucinous differentiation in the areas of mucocytic differentiation. The outcome, of course, is quite stage and grade dependent. So here, if I just showed you this as a single image, this is showing the surface epithelium of the oral cavity, I think you would say, wow, that looks like just a clear cell neoplasm, and how you would be able to separate this between any of the various lesions that I'm discussing, just looking at that one field, would be really quite difficult. However, in other areas, you now begin to see more of the transitional cell component over here, with a bit more prominent transitional and epidermoid area here. But again, these cleared cell spaces don't automatically equate to being mucicarmin positive. In an area like this, where you have dense sclerotic hyalinization with an inflammatory infiltrate, now you're able to see a much more well-developed mucocytic differentiation along with the intermediate cells, but still the prominent finding of clear cells is easily noted in this field. When you look at the immuno, the tumor cells here are positive with P63. There is an internal control with the overlying surface, as you can tell from this tumor, and CK56 is strongly positive as well in the neoplastic cells. So again, when you look at these two tumors immediately adjacent to one another and think about a clear cell mucoepidermoid carcinoma and hyalinizing clear cell carcinoma, it is often almost impossible in some cases to be able to make a legitimate separation between these tumors. And so in some instances, after you've performed the immunophenotype and seen that there is complete overlap, because hyalinizing clear cell carcinoma can have mucinous cells present within it, it is in those settings that I will actually do a sequential molecular finding. So, many times you have kind of a weighted feeling. So you think, oh, this is probably going to be a clear cell mucoepidermoid carcinoma. And so I would do the MAML2 first in that case. And if it came back negative, then perform the EWSR1. So a sequential approach to this is helpful. When you think now about the costs of the FISH probes, somewhere in the range of $250 to $400, depending on who you use and where you get it from, you can tell that it's more expensive than getting an immuno, but it's not quite the $5,000 of a molecular study that we used to have several years ago. Here is an example of MAML2 as a break apart, just showing you that it is quite helpful in these settings, although of course all of the fish look identical to one another. You can't really tell which probes are being used just by looking at it here. Let's now go to a myoepithelial carcinoma. In this particular case, I think the idea that you're dealing with a malignancy that is made up exclusively of myoepithelial cells. Obviously, because it's a carcinoma, there is going to be invasive growth, and you can tell that the palate is much more frequently identified than other anatomic sites with the submandibular gland following. However, I will say in the major salivary gland locations, myoepithelial carcinoma, epithelial-myoepithelial carcinoma, and salivary duct carcinoma are the three most common carcinoma types in the carcinoma X pleomorphic adenoma category. And so many times in a major salivary gland, if you have a pleomorphic adenoma that has transformed, a myoepithelial carcinoma category is certainly going to be something that can be seen. This is probably one of the most difficult tumors to identify because it has such a wide diversity of architectures from solid, trabecular, and reticular with a concomitant diverse morphology. So in other words, you can have spindled and epithelioid cells, plasma cells, vacuolated and clear cells, solid cells. It is a really very difficult and challenging area. And then, of course, when you think about the stroma being either myxoid or mucoid or even hyalinized in some cases, you can tell how it will immediately overlap with some of the other categories that we're discussing. So again, this is a single cell population, right? Because it is all being derived from myoepithelial cells. So even though they may have multitude of architectures and diverse morphologies, they still are all going to be a single cell population. But because it is myo and epithelial, the epithelial markers of keratin, CK14, P40, P63, CK56 are going to be positive, but also the myoepithelial markers will be present as well. And actually CK14 is a fantastic myoepithelial marker with SOX10, S100, GFAP, smooth muscle actin, calponin, whatever it is you like, to be able to perform a immunophenotype. I will say these are quite dependent on the lab. So many times I will get someone who has sent in a case for consultation and they'll say, oh, the muscle markers are negative. And then I repeat them and you will have positive reactivity. So many times this can be clone dependent. So when one thinks about myoepithelial cells as a whole, the actual native myoepithelial cells as they are involved in the salivary gland architecture do not necessarily stain the same way as a neoplastic myoepithelial cell. And so this is why I will often perform 3 or 4 different myoepithelial markers in order to be able to confirm the diagnosis, because you may have a fantastically positive SOX10 and the smooth muscle actin and GFAP will be completely negative. So it is a tumor category where I do tend to do a few more markers. It is also important to recognize that the myoepithelial carcinoma clear cell type can have EWSR1 rearrangements. And so again, I think you have noticed already just with the presentation up to this point that I've spoken about EWSR1 quite frequently in these tumors. And so this is also to highlight that the molecular findings in some of these cases does not necessarily help to define the tumor without having an approach that includes areas of both histology as well as immunophenotypic expression. So here is an example of a myoepithelial carcinoma, I think, with a very heavy stromal hyalinization. In this example with remarkable clear cells, again, it's going to fit into any one of the tumor categories that I've just described, an infiltrative architecture, kind of a nested trabecular or even cord-like pattern can be seen. Other areas here showing very well developed myxoid stromal component in a nested architecture, another area showing kind of nests and cords separated out by these myoepithelial, by the stromal myxoid background. Now you can tell from these that there is cleared cytoplasm, but it is not always the case. So I am highlighting it here because we're talking about, clear cell tumors and their differentials, but just recognize that myoepithelial cells can be eosinophilic to opaque cytoplasm as well, and not always just a clear cell compartment. The nice thing about the immunophenotype in this case is that, again, it's going to be a single cell population, but with a variety of different markers. And let me just show these to you now, where you can see a strong and diffuse pan-cytokeratin, strong and diffuse P40 in this example, a little bit more patchy with the CK56, but again, you can tell that it is highlighting the majority of the neoplastic cells. Calponin as a example of smooth muscle, very nicely reacting in this example. S100 giving you both a nuclear and cytoplasmic reaction, and then a very nice and prominent reactivity with SOX10. I will say the SOX10, because it's a nuclear reaction, is actually much easier to interpret in many cases, and usually it's a very strong and diffuse reaction in all of the neoplastic cells. So whenever I have a salivary gland tumor and there's any sort of hint of clear cell architecture, SOX10 is definitely one of the stains I'm going to do because it is quite helpful in coming up with a diagnosis. Just a point of clarification here around INI1. If you think about the soft tissue myoepithelial carcinoma category, quite frequently they are associated with an INI1 loss. However, for the salivary gland tumors, the INI1 is usually maintained or intact, as you can see here, with all of the cells strongly positive. And therefore, sometimes if you're making a separation between is this a tumor of soft tissue derivation or salivary gland derivation, especially if you have a core needle sample that doesn't include any native tissue, you may want to say, well, if the INI1 is lost, it may potentially be a soft tissue tumor that is invading into the salivary gland region, rather than necessarily being a salivary gland primary that's expanding into the soft tissues adjacent to it. So again, when I put these two tumors together, I think when you think about a myoepithelial carcinoma and a hyalinizing clear cell carcinoma, again, the overlap can be seen, but the immunophenotype can be very helpful in separating between these biphasic versus single cell population. Let's now go to the epithelial-myoepithelial carcinoma category, kind of as the next in the spectrum, because here you have a salivary gland tumor that is, again, biphasic, tightly coupled inner ductal to prominent outer myoepithelial cell tumor. As I already mentioned, it is quite frequently the carcinoma in the carcinoma expiomorphic adenoma category. Usually it's quite nodular or bossulated in its overall appearance, giving you these nodules that expand out into the adjacent parenchyma rather than necessarily being well circumscribed. Outer luminal cells, the inner luminal cells are the ductal cells, and they are surrounded by a very well-developed abluminal cleared myoepithelial cell, usually in a single layer, but you can have multiple layers present as well. And let me tell you that sometimes there can be a myoepithelial-rich component where it almost completely obscures the lumen or compresses the lumen into a slit-like space, and that can be much more difficult to recognize, especially on just standard H&E. And so this is where the immunophenotype will be quite helpful. So the luminal cells are going to be positive with CK7, and then the abluminal cells with a variety of different myoepithelial markers. And you can see, again, the SOX10, smooth muscle actin, calponin, etc. Many of these tumors will have an HRAS mutation present, and this is why the RAS immunophenotype can be seen in some of these cells, especially in the luminal compartment. So, if I showed this just as a single cell area, a single image, I think you can tell that there is some area here where there's kind of a more luminal compartment with the cleared cells around it. Another area down here where you can tell that there's a suggestion of a lumen surrounded by clear cells. But again, just this one field, it would be very, very difficult to say this is an epithelial-myoepithelial tumor. However, as you go from this space where it seems to be almost a single cell population, even though it isn't, but it seems that way, and then you go into an area like this and you can see that it just transitions imperceptibly. Now you can tell that that luminal component, although the lumen is compressed, does have a different appearance than the surrounding myoepithelial cell compartment. And so when you think about these tumors, and here on low power, I think now you can really tell very nicely that it does have those central luminal or ductal appearance with the surrounding myoepithelial cells. And then when you go on to high power, now you can tell a very well-developed area with even some secretions present here, a nice duct here surrounded by the clear cells, kind of in a single cell population group in this example. I think here you can see, though, that the myoepithelial component has taken on a spindle cell morphology. And in a spindle cell morphology, you may not even get a hint that you're dealing with a biphasic appearance to this neoplasm. However, when you do immunophenotype, here a full field, showing you the CK7 where it's only highlighting the luminal cells, and then any one of a variety of different markers. I'm only going to show the smooth muscle actin, but just be aware it would be identical with any of the myoepithelial markers highlighting only that surrounding clear cell component. So when these two tumors, especially when they are quite well developed, are set next to one another, I think the biphasic appearance of the epithelial-myoepithelial carcinoma can be quite easily separated from hyalinizing clear cell carcinoma as an entity. Let's now go to acinic cell carcinoma. And the reason why I've included this, originally I didn't think I should, but then the more I thought about it, it is a tumor that shows serous acina differentiation by definition with the zymogen secretory granules. But it is made up of a wide variety of different cellular components. And I think that is something that needs to be emphasized. And so I'm going to show that to you now. As you will tell, major salivary gland accounts for by far and away the most frequent number. And in fact, if I think about acinic cell carcinoma in minor salivary glands, it probably isn't. In other words, it probably represents a secretory carcinoma or some other category of tumor rather than representing an acinic cell carcinoma. It really is a tumor that develops in major salivary gland locations. There are a number of different patterns, solid, microcystic, papillary, and follicular. The patterns don't really mean anything, but it's just to show that they do have them, and of course can be seen in quite a wide variety. So this would be a solid pattern. Here you can see a microcystic or fenestrated appearance with, multiple sieve-like openings. Here is a papillary architecture to this tumor, and then of course a follicular pattern as a mimic of what you see in a thyroid carcinoma, hence the name for follicular with the secretions present in the lumen. So this is what I mean by multiple cellular types. And of course, the serous acina cell with its very large polygonal cell, lots of abundant basophilic granules showing a strong resemblance to normal tissue with these very coarse zymogen granules is what we look for in the tumor and needs to be identified somewhere in it. But then when you think about it, there are also going to be intercalated duct type cells that are slightly smaller, non-specific glandular cells that have kind of a polygonal to round cell appearance with amphiphilic to eosinophilic cytoplasm, lacking any granules. And then the clear cells, these are non-staining, they're very prominent cell borders, and it's not related to glycan, and it's just cleared out cells. And then finally, vacuolated cells can be seen as well with a negative PAS and mucicarmin. So in other words, there is no evidence of mucinous differentiation in this tumor. So again, when you look at these neoplastic cells, this is the serous acina differentiation that we all look for in the tumor and needs to be identified somewhere. I think you will see that they're very coarse granules. They're easy to identify on a standard H&E. This happens to be at 40x, but I think even at a 20x, you can certainly see the well-developed granules in the cytoplasm. However, as I look at this and begin to see the non-specific glandular cells and some of the intercalated duct type cells, you can tell that there are isolated cells in this group that still have the area of serous differentiation with nice granules present in the cytoplasm. But now not every one of the neoplastic cells has that particular feature. And then if I go here to the non-specific glandular cells, it's a nice glandular appearance. But if this is all you had, I think you'd be very hard pressed to at least consider an acinic cell carcinoma. And perhaps if this was the cell population you had, which is now the clear cell dominant finding, and if the entire tumor had this clear cell morphology, I think it would be very difficult again to say, is this an example of an acinic cell carcinoma? So it is an important consideration to be able to say, what is it that I'm dealing with? And in this case, immuno can certainly be helpful. I think, first of all, though, that the PAS positive diastase resistant zymogen granules are very easy to accentuate with that stain, and it is one that I usually do. I find the immunos to be a little bit more challenging to interpret. DOG1 is certainly the one that is most frequently used, but I still think that it is quite difficult to interpret with its canalicular pattern and very, very delicate luminal reactivity that I'll show in a moment. Of course, it will have NR4A3 positive as well. And as you know, this is seen as a recurrent rearrangement in about 80 to 90% of the tumors, and therefore it is one of the markers that can be used, while other fusions can be seen in a smaller subset of lesions. So here is an example of that PAS. I think you can tell that it is nicely accentuated, specifically here around the luminal aspect or the luminal border. And so they really will aggregate around this space and very easy to identify that these are the zymogen granules. As you would know, a positive reaction with DOG1, again, is quite similar, where it highlights that luminal aspect or the canalicular architecture of these tumors. And so you get a reactivity pattern that is very delicate and still positive, but very delicate along that luminal border. So it isn't something that highlights the entire neoplastic cell. By contrast, NR4A3 gives a very strong nuclear reaction, and you can tell the adjacent salivary gland parenchyma in this case is completely negative. Here's an example of just a full field where the NR4A3 is seen. And I will say, especially in salivary gland, this is a unique finding in acinic cell carcinoma. Clearly, the NR4A3 is seen in a whole variety of other tumor categories elsewhere in the body. So it is not necessarily going to say this is acinic cell carcinoma only. But even when you have high-grade transformation of an acinic cell carcinoma and more of a sheet-like distribution, loss of the zymogen granules, this stain is still seen, and therefore it is grade independent, and so can be quite helpful when it is seen in that particular setting. Again, putting these two tumors together, they do have histologic overlap, but I do think that they can be separated quite nicely by doing a targeted immuno or histochemical evaluation. So now we get to the final tumor, metastatic clear cell renal cell carcinoma. And because you're talking about clear cell tumors in the head and neck space, metastatic tumors as secondary lesions certainly will come into consideration here as well. And most importantly, it is when the tumor primary is occult. So in other words, no one yet knows about the presence of the renal cell carcinoma. And so without knowing about it, you're saying, oh, this looks like renal cell carcinoma. Oh, they don't have a primary. But then when they do the imaging, they will often see the tumor. So just remember that the kidney clear cell carcinoma category quite frequently will present with metastatic disease to the oral cavity or to the salivary glands, and it will often maintain an architecture quite similar to the primary. So an alveolar pattern will be seen, extravasated erythrocytes, cleared and prominent eosinophilic cytoplasm, and then prominent cell borders. Again, this is a single cell population, but other than the CK-pan, which of course we haven't really spoken about with several of the other tumors, the presence of PAX8 or CA9 along with CK7 is certainly going to help with that separation. And so probably doing a PAX8 in several of these clear cell tumor categories would be of assistance in separating out that particular category. So when I think about it, this is a slightly vacuolated appearance to the clear cell, just as an example of some variation that you can see, versus a tumor like this that has a much more clear cell pattern, an alveolar distribution, very vascular with extravasated erythrocytes easily identified. Strong positivity of the membrane with CA9 to highlight the origin of this tumor, with PAX8 also being seen. So as I now consider this particular tumor category as a whole group of entities, I hope that I have been able to highlight several of the features that can be seen and be used as separation between them, but also to recognize that there will be some tumors where you are not able to make the separation just based on histology and special studies, and will need to actually go to molecular evaluation, and then still recognizing that many times the EWSR1 may in fact be present in a number of these tumors as well. So you may say, what was this kind of weirdo distribution, and why did you have it in that particular order? Well, you know, when you think about all of the tumors we have to consider, I do try to come up with some sort of mnemonic. If you take the first letters where, you know, the A is going to be adenosquamous and acinic, and the S for squamous and sclerosing microcystic, hammers is what you're spelling, right? So hammers is what you have. And I hope that I've been able to hammer that home here as I put myself into one of the Marvel characters. So when everything becomes easy, when all you have are hammers. So with that, I hope that I have been able to clear up some of the findings that you can see in salivary gland clear cell tumors, especially with their differential in the head and neck that will encompass some of the other tumors in the lesion. Well, with that, I thank you for listening, and I will be more than happy to take any questions and hope that you have a fantastic day.